Hello, we'd first like to take a moment to thank you for your time and attention to a topic that we believe is incredibly important and will make a huge difference in the care we provide to our patients living with dementia. I'm Dr. Pam Compton-Dooley. I'm an assistant professor of nursing at Longwood University in Farmville, Virginia. My colleague, Marion Kiner, is an adjunct faculty at Longwood Department of Nursing, teaching dementia skills to our nursing students. Today, we'll discuss the impact of experiential dementia training on our students' perception of knowledge, comfort, and confidence. We'll show the value of experiential learning in caring for persons living with dementia and share with you some valuable lessons we learned at Longwood with regards to our Getting Connected training. And lastly, we'll share some barriers of integrating this training into our community. Our goal through this training is to enhance the way we teach our students to care for persons living with dementia and how to truly connect with them, which in turn will make their communication much more effective. Changing the way we approach care for persons living with dementia requires a change in the way we educate our students and understanding brain changes in dementia and using communication. I think it's imperative that we start with why. The statistics are staggering and speak for themselves. Dementia affects over 55 million people worldwide, and according to the World Health Organization, 1 in 3 seniors die with Alzheimer's or another dementia. In 2021, one of our senior nursing students came to us after hearing Marion speak in a sociology lecture and said, "You need to talk to our nursing classes. Other students have said we don't feel comfortable talking to patients with dementia." Of course, we have dementia lecture, as most nursing schools do, in several places within our curriculum. I teach in the sophomore level, and so I knew we introduced dementia training and dementia in fundamentals in nursing courses. We have a 3-credit geriatrics course at the senior level, and there's a dementia lecture in this course as well. As we began researching, we found the literature reveals that not only do nursing students struggle with caring for persons living with dementia, but so do nurses that are out in practice. We took this concern to the chair of our nursing department, Dr. Kim Little, and an idea was born. This is Marion's field of expertise, and she'll get to the nuts and bolts of our training in just a moment. The ultimate goal of our experiential training is simple: to learn positive communication approaches to get connected with our patients. The experiential training will increase confidence and comfort when working with patients living with dementia. It'll help students understand and recognize brain changes, particularly in language and vision. The training will allow for practice of hands-on skills that enable our students to make true connections with our patients. The training will also help students begin to identify the stages of dementia. So we rolled out a 6-hour experiential dementia skills training. We started with our seniors and then decided to back our training up to our sophomore nursing students. Fall of sophomore year is when our students take fundamentals. It is in the fundamentals course they begin developing and practicing communication skills and interactions with our patients. Fundamentals is our first clinical course, and the students have 56 hours of clinical with a focus on long-term care. We used a pre-test and a post-test on knowledge, comfort, and confidence before and immediately after the 6-hour experiential training. Then a follow-up 2 months later to collect data on the students' self-reported skills in caring for patients living with dementia.
So we incorporated the Positive Approach to Care model by Teepa Snow. I'm certified as a Positive Approach to Care trainer and coach. And so we put it into a 6-hour training and titled it Getting Connected, Experiential Dementia Skills. So it's about the relationship. And we all know what it feels like when we have a relationship that goes like this, and we know what it feels like when it goes like this. And what I tell students is that first 15 seconds of making this kind of connection so you can develop that trust with the patient. When it goes like this, we need to step back and ask ourselves, what am I doing? What's going on here in this situation that I need to do something different? And so experiential learning is ideal for teaching this kind of skills. First of all, it builds in those nursing competencies that we're looking to build into nursing curriculum in terms of communication skills. Experiential learning helps to develop empathy. We know from the literature using experiential models like virtual dementia tour it's helpful to develop empathy. And we also look at dementia in terms of brain changes as opposed to what is the pathology that's affecting the nerves, because it really doesn't matter what is causing the damage. It really is about what area of the brain is affected and how that is impacting a person's ability to function and to communicate. And so we look at brain changes. And then we also do a lot of skills practice, and particularly skills practice around challenging behaviors. And so we do role playing throughout the whole training and throughout the day. In fact, what the students tell me is that the best part of the day, the role play. Who would have thought? And so the model is like this. This is the adult experiential learning model that we use in the positive approach to care. It starts with an activity. We get an experience that the students go through, and then we stop and we discuss it. We share, we talk about what was that like? What did it feel like? What did you think? And then we talk about the why of that. Why did that happen that way? What was going through your mind? What do you think would have been different? And then we say, well, how does that connect with a person with dementia? What would they be experiencing? What is it like for them? And then we say, so what will we do different? What kinds of skills, what kind of things can we do different with this person? So let me give you an experience of what that's like. Let's do an experiential activity. So normally we have a visual field of center vision, that's for curiosity, that's where we look. And then we have peripheral vision, and that's for safety, so we see things coming at us. And normal vision, an 18-year-old can see their fingers, I can't see mine. So our normal vision, we start to lose peripheral vision. And as we age, we lose more. And that's why we fall a lot. And that's where car accidents come in. But with dementia, our brain cannot process all of this visual data coming in. And so the visual field comes down to what's called tunnel vision or scuba mask vision. And this is an early stage of dementia. Many times people aren't even diagnosed yet. And yet this is their visual field. And as you can tell, I can't see what's coming at me from over here. I can't see my walker. I can't see the whole room. And then in mid-stage, it goes down to binocular vision. Wow, a whole lot more is taken off. I can't see the table. I can't see if you're touching me. Imagine if somebody comes up to you and you have this kind of visual field and they lean into you, what that feels like. So we were talking about it. Boy, is that ever intimidating. Somebody's getting in my face. It feels like they're attacking me. And that's what people with dementia experience. And we often see them doing this kind of thing to push us away because we're really triggering their fight or flight. And so what we want to do as an approach is we get in their visual field, but then when we approach them, we get to the side. We turn so that we're allowing them all this space to feel open and not like they're being attacked. And so that's one of our experiences we do in our training. Here you can see me practicing with the students and modeling for them. This is the positive physical approach where we get in their visual field and then make a contact and get to the side. And then this is the students practicing their visual changes as we just did. And we use tanning goggles kind of for fun, but you can see in binocular vision that has that hole taken out of the tanning goggles, and they have a lot of fun with that. And we do some practicing. And so as an anecdotal comments that students have made, when I go into their class a couple months later, after they've been out in the clinical setting, and I'll just ask them, so how did it go? What are you using? How are you doing with the skills? What I'm looking for is, did they learn about brain changes? Are they able to assess for brain changes? And did they learn the skills? And it's amazing what they say. They talk about, so I knew that she had vision changes because she had one eye closed, and so I knew I had to get where she could see me. Or they'll say that I look for how are they, what can they do, and how do I need to gauge what I do with them based on what they're able to do. So they're using assessment skills there. They're also talking about they're using visual cues and gestures because they know that the person has a limited ability to understand the words that we use, or they're using the hand under hand to help support the person. Students also have commented that they have more confidence going up to a person in comfort, just talking to somebody now. And they say that they have tools in their pocket. They feel like they were given tools. These are comments coming straight from the student. And my favorite one is that they begin to see the person as a person, the patient as a person.
So we certainly learned a great deal, and our data that we collected immediately after the training showed that students' knowledge improved, but comfort and confidence did not. So we believe that's in part attributed to the timing of the post-test or the survey in relation to their clinical experience. We know that there's more work to be done, and we're looking forward to making changes to improve the students' comfort and confidence in caring for persons living with dementia. So we know for sure that in order to change the way nursing care is provided to persons living with dementia in our communities, that education and training must start right here with us in nursing school. We also recognize that change in the way we teach content requires thoughtfulness and diligence. We recognize we have curricular changes. We need to know where the perfect placement is for this training within our curriculum. How can we ensure the students have adequate time to practice their new skills? We believe that as we move toward competency-based nursing, the experiential dementia skills training will be a perfect fit. As the positive approach to care, skills are effective for all patients, not just those with dementia. Other barriers include having instructors or faculty that are well-versed in the training, and the time to develop these skills and practice is also a challenge. Clinical sites, as we all know in nursing education, are at a premium and certainly challenging. We're excited about the steps we've taken to address and integrate the experiential training into our curriculum. We've gained some very valuable insights and will continue to work hard to bring experiential skills training to our students in an effort to make the lives of persons living with dementia better. Thank you again for your time and attention. If you have any questions, please feel free to reach out.